Tēnā koutou, tēnā koutou, tēnā koutou katoa. Welcome everybody. I just had a little bit of a water spillage over there, so sorry about that. We'll tidy that up. I'm Denise Cosgrove. I'm the Chief Executive of Presbyterian Support Northern, and I'm really delighted that you've taken the time to join us this morning. So look, we're really excited to have been bringing this lecture series to you, and we're nearly all the way through. We've got one more here in Auckland next week, which is the Minister for Social Development, Carmel Sepuloni, who is closing the series. So we do encourage you to come along to that as well. But we have been able to, and been humbled in lots of ways, to bring a range of very fascinating, controversial, challenging speakers here from both New Zealand and overseas, and to actually discuss and debate how we can improve the well-being for our children, for our tamariki. So it has been a really great series, and I've learnt so much along the way, as so has the board. We were discussing at our last board meeting about some of the learnings that we've had, the challenging thoughts that we've had around the way we evaluate things, what more we could be doing. So I think it's been really, really great. We've taken an approach which is that we have a range of services, as you probably know, which are up there on the board and on your chairs, but they're primarily focused around strengthening and building the capacity of individuals to respond to whatever is going on in their lives. But at Presbyterian Support Northern, overall, our focus has really been on the system level and building the capacity of the sector, the system and the community. And that's why I'm really, really delighted today, because I just discovered that our guest speaker today, Mina Fazel, who is an associate professor in Oxford, has a particular interest too on the way the system functions together. Mina, I really, just even in the short time I've known you, I love people who have a really clear focus on where they want to make an impact. And your impact is really around access and around using the school as a point of access and a priority setting for improving mental health and protective factors for children. Mina has a special interest in refugee children, and I learnt some whole new words this morning: narrative exposure therapy for PTSD in refugee children, and the concept of flooding. So I will leave that to you to describe. But we're really excited to have you here today, and we look forward to your lecture. Let's welcome Mina.
Thank you, and good morning. Very, very nice to meet you. So I'm here, so as you kind of described, I'm a child and adolescent psychiatrist. I work in Oxford. So I work for kind of 20 years. I've been interested in issues around access and how children who really need mental health services, how to facilitate their access. And I started working with refugee populations, which led me to working with all populations in schools. I also work clinically in a general hospital with a chronic pain team in something called a psychological medicine service as well. So what I want to do today is talk you through kind of some of the tasks and complexities of adolescence, and then think around the role of schools, think a little bit globally, and then about some ideas about what potentially can be done. I'm here to be of best use to you. I'm more than happy to be interrupted for questions during my talk and also at the end as well. So it's really important to think about adolescence and childhood, really. There's quite complicated developmental tasks that young people need to get through, really, in a relatively short period of time. So it's a sensitive period of brain development, and kind of peer group influences are quite prominent. So there are kind of all these factors interplaying around family, peers, cognitive development, academic achievement, behavioural development. Alongside all of that, you kind of got to grow quite a lot physically. And interestingly, there's only one other animal, that has a period similar to adolescence of kind of rapid growth. Most other animals, almost every animal, grows just on a kind of steady trajectory. But actually in humans, we have this thing called adolescence of kind of rapid, dramatic growth. And that's important because that's also a time where pathology can creep in. And that's why we see things changing quite dramatically in adolescence, and why it's so important to really be thinking about this period as well. You've got young people needing to develop a moral code of some sort. And I suppose the main task of it all is what we call individuation, where, at the end of this whole process, you become an individual who's able to kind of live an independent life, contribute to society, continue to learn in certain ways and work, but also to be able to have left the family context in which they're in. But what we know is that there are also sort of kind of difficulties in adolescence, so globally the prevalence of problems is around 10 to 15% of children around the world will suffer from mental health difficulties in their childhood. And so what we also know is that the evidence is that this is increasing. So anxiety disorders and mood disorders are increasing. Around 2007, which most people attribute to the time of global austerity starting, actually a lot of the indicators are getting worse. And so, in a classroom of 30 kids or so, you've got to think about kind of 3 to 5 children in every classroom are likely to need some additional support during their school years. So what are some of the additional modern, maybe not, complexities of childhood? So the first is puberty. I'm not going to go into kind of how terrible puberty was for me or all of the rest of us, but actually just the concept that actually puberty, there are indications that puberty is starting at a younger age. And so thinking about risk of mental health problems, that might be one of the reasons why we're seeing more problems. Because actually, if you start puberty younger, your brain exposure to the difficulties is taking place starting at a younger age. And so what you get is greater sociological and sexual pressures. You often get earlier alcohol and drug use with early puberty. You get impaired relationships often, and more mood and alcohol disorders. So it's really important to think, it might not all be about society. It might be just the biological things taking place in young people that are making them more prone to risk. Then we've got sleep. So it seems to be that sleep is just disordered for adults as well as, and not just for jet-lagged adults, but for everybody really. So if you sleep less, actually melatonin, it seems to be an anti-pubertal hormone. So if you're sleeping less, you're also more likely to enter puberty earlier. And actually, from what we're learning about risk factors for the whole range of mental health problems and the worst outcomes, disordered sleep patterns seems to be a consistent factor across the board. Then we've got kind of dramatic changes in family life across the board. Actually the concept of the nuclear family is changing as young children are much more exposed to different configurations of family life and potentially more exposure to conflict and discord as well. And then I suppose a lot of these kind of pressures to perform, I put it as a little bugbear about, I don't know, school was bad enough, but I didn't have all the additional pressures of kind of all these testings that go on all the time now for children, and kind of that I don't think is going to be easy. And then kind of just global austerity and the pressures of kind of socioeconomic decline, poverty, social fragmentation that comes along with that. All of these are important risk factors for mental health problems. And then social media, I put there, like, we don't really know what the impact is. There's likely to be a lot of positives with it, but what we know is that if you increase your use, you're more likely to have a whole range of risks. There are other trends as well. There's increased help-seeking behaviour. It's kind of improved recognition amongst professionals of mental health problems. A little bit of a medicalisation of feelings and behaviour. So if you're feeling low, it's terrible, you've got to see a psychiatrist immediately. So who knows really what some of the trends are. So what do we know about the median age of onset of mental illness? Well, it seems to really all be happening really early on. So, in your mid-teens, basically, it seems that, the vast majority of lifelong mental illness seems to have started. And the evidence suggests that 75% of lifelong mental illness has started before the age of 18, 50% before the age of 15. So this is all happening in the school years, which is why these years, I think, are so crucial. A big study published a couple of years ago in Australia showed kind of also a strong continuity of depressive symptoms from adolescence into adulthood. Not necessarily as strong for anxiety, but definitely strong for depression. And then, what we know is that more severe disorders are preceded by less severe disorders. And I'm aware that there's a lot of concern in New Zealand around suicide and self-harm rates, and this is just a slide to show us and remind us really of the prevalence of suicide, which is the top of these icebergs. That actually, there are about 20 attempts for every one serious attempt. There's a lot going on in the community around self-harm. Well, what I'm here to talk about is schools, and so I think it's important for us to think about what is the relationship between education and mental health. Because actually, it's a really, really delicate balance, I think. I don't think these are two separate things. It's not okay, as some teachers say to me, mental health has nothing to do with us, we're here to educate, Basically, we know that if you've got mental health problems, it affects your academic performance. And if you've got learning difficulties and difficulties with the academic performance at school, it's likely to affect your mental health. So this is a really delicate, intricate balance. Actually, they're not separate entities. And so we've got to think when we're kind of looking at education and schools that, 40% of young people experiencing depression or anxiety are likely not to complete school. So it's a really big impact on education. And a large meta-analysis of school behavioural health programs shows convincing effects on academic achievement. So doing things to improve mental, social, emotional difficulties does help educational outcomes. We've got a big 55-year study in the UK, and it showed that if you had childhood mental illness, you were twice as likely to be unemployed later on in life and to be on long-term sick leave. So these are kind of profound, persistent, long-term impacts. And this is kind of, I suppose, my area. It's about this whole issue about how do you access care, actually. If you've got difficulties, how do you access care? I could talk about this forever, actually, so I'm not going to. I'm just going to say it's really, really difficult and really, really complicated. That 60% of young people who need services, in the majority of services around the world, don't access it. So let me show you in the UK what that looks like. So, you've got 40% of kids who are kind of accessing mental health services, and we've got pretty good evidence-based interventions that can help. But, what's happening for those that aren't accessing care? So they're not getting care, but they are going to school. Vulnerable populations are overrepresented in the groups that are not accessing care. And school staff are spending a lot of time supporting these kids. They might not be doing mental health interventions, but my God, they're doing a lot to support these kids. And so I think it's really important for us to think about kind of what is happening for that 60%. Now, if I change this slide and I said 60% of kids with diabetes were not accessing services, there would be a public outcry. What is going on that it seems sort of acceptable that 60% of kids with mental health problems are not accessing care, and it seems to be okay? Yeah.
Are you saying that 40%, that 10% of the 100, are you just saying they're mental disorders, or do they have possible physical disorders as well? Or?
So that's just for mental health problems. So likely to benefit from input from mental health services. So a proportion of those are likely to have comorbid physical health problems as well. So we know there's a very high correlation of those. But, if we had 10% of the population with diabetes, but 6% of them weren't accessing care, that just would be felt to be unacceptable. And this is, I suppose, what we're starting to talk about more is this thing called parity of esteem. Actually, we need to be thinking about mental health problems in the same light that we think about other things. So let's think specifically about schools now. What's happening in schools that's of interest mental health-wise? Well, I think the first thing we need to think about in schools is that you've got teachers there who play such a key role in kind of developing and nurturing and, training the next generation. Yet actually we're not necessarily treating our teachers with the respect and the care that we need to. We don't necessarily give them the salaries they deserve. And what happens is, and in many countries, 50% of teachers have left the profession within 5 years of starting. And many of the reasons why they claim they are leaving the profession isn't because, they don't know how to teach. It's because actually the social emotional difficulties in the classroom have been too difficult for them to manage. And often it's one or two children in particular that have tipped them out of the profession. And so how important it is for us to think about teachers and the importance of stress in teachers. So there's this concept called stress contagion, that studies have shown that stressed teachers who are more stressed, the children who enter their classrooms in the morning have higher cortisol levels, which is a marker of increased stress. So actually, this kind of burnout cascade also in teachers, where you're stressed, you've got kids now that are playing up a bit more in your classroom because they're picking up on your stress, and it just kind of exacerbates the problem. So we really need to think about the important link between teachers' occupational stress and student stress, and also just how really to support this, because actually a poor relationship with your teacher is a big predictor of future mental health problems in children as well. You're more likely to have low academic attainment and increased stress as a child. And there are quite interesting studies now looking at teachers and how to support teachers, providing interventions with teachers, and how that has knock-on positive effects for children. The next thing I think that's important to think about in schools is this thing called peers, which obviously the whole point of adolescence is that your peers become far more important than your parents. But then in school in particular, children get exposure to bullying. And from a mental health perspective, one of the most toxic risk factors for lifelong mental health problems is exposure to peer victimization and bullying. And so if we're really serious about the mental health of the next generation, we really, really seriously need to be thinking about full system ways to address and tackle bullying in a really important way. So, there are lifelong impacts of bullying, casts a long shadow in the kind of course of a young person's life. In the UK, up to 40% of children say that they've been bullied at some stage. But persistent bullying is particularly toxic, particularly for girls. Children who have been bullied have increased suicidal ideation, and adults who report bullying in childhood have increased rates of anxiety, depression, self-harm, and unemployment rates. So this is kind of really, really complex and important. And then obviously my little bugbear about all these kind of tests and exams and kind of what stress that provides young kids. So let's get to schools. So the thing I think I really want to say is that schools provide a unique platform to access and support psychological difficulties in children and adolescents. So, as a child psychiatrist, I can't access all kids, but schools are where the kids are. And I often say to teachers, the most potent mental health interventions that I can think about are totally unavailable to me, but they're fully available to teachers in a school. Like if you identify that a kid's withdrawn, that actually within the classroom of structured and unstructured settings, you can identify problems earlier. You're able to facilitate their peer networks, formally and informally. You can create projects, put them with the kids in the class that you think are most likely to support them, make them feel that this is just part of normal school life, help them build their self-esteem, help them build their outside interests. I can do none of this if I'm in a clinic in a mental health unit. But actually a teacher has within their capacity and grasp the ability to do all these things. So whether the poor teachers like it or not, I think they're working in the most potent mental health intervention arena there is. And so I think our task is to think, how can we support that environment? What can we do? We shouldn't assume that only teachers do that work. It might be that their lay people can come in and do that, other services can come into the schools and do it. But I think the important thing is that schools are where children are. It's the kind of most profound kind of available institution that the kind of children are attending nowadays. And so they seem to be the biggest provider of mental health services, schools, whether they want to be or not. And And I think, what we understand from the States, where actually the school mental health movement has been established for over 25 years now, that in America, health services in schools started to address dental care and sexual health. That was the reason that, there's different health service system over there. But they found that when they brought mental health into the school context, the majority of utilization of these services was for mental health needs. And so the potency and importance of accessing young people for their mental health needs in schools became really evident. And we've got to think these problems are persistent, and if we're aware that kind of vulnerable populations aren't accessing care, then we've really got to be thinking about the role of schools. So what do I mean by school-based? Have I gone the wrong way there? What do I mean by school-based mental health interventions? So I think the first thing we need to think about is who gives the treatment. I'm sorry if you can't see the slide, I'll talk you through it. So basically, the who gives the treatment can be anything from those within the school, peers, teachers, to outside the school, so kind of other agencies, mental health services. So when you talk about mental health services, mental health interventions in schools, who gives it can be a whole range of different people. And then to whom is also important, like, is this interventions for the whole school? Is it interventions for a classroom? Is it interventions for children who are identified at risk? Or is it interventions for children who already are exhibiting symptoms? So when you want to work at a school, you've really got to know what you want to do. And then, what to do. Like, is it CBT? Is it family therapy? Is it counselling? Is it art therapy? Like, what is it? And then I call this kind of the last area kind of really important prevailing issues. So the evidence base. Well, given that every single person really has gone to school, it's really shocking how poor the evidence base is for interventions in schools. I think consent is a really complicated issue. Like, children need to know and understand who knows what about them and their well-being, and do their parents need to know, do they not need to know? And actually the working out the intricacies of this can be a major reason why these services don't develop in the first place. Because, nobody knows whose right it is, whose wrong it is, whatever. So it can be difficult. The whole concept of confidentiality when you're working in a school is very different. Who's going to know, who's not going to know. And I think that's an important issue that, because it's quite complicated to work at, impedes services developing.
Excuse me,
yeah.
Lift your voice up a couple of...
Sure, sorry. Is that better? Can you hear at the back? Yeah. And then the last area, I think, is whose responsibility. So is this health or is this education? So, who's going to pay? And because no one really knows, a health need in an educational setting, then kind of nothing seems to happen. Or health puts something in, education says, right, we can put less in, or education puts something in and health goes, right, yeah, we never thought it was our responsibility, now we know it's not our responsibility. So this kind of battleground means that actually very few people stand up and go, right, let's find a joint model of care. So let me just talk you through the different types of interventions that can take place in schools. So there's mental health promotion, prevention, and treatment. So I just want to talk you through each of those areas. So promotion is kind of improving the general well-being of a school environment and the young people at the school. These are usually what we call universal interventions given to everybody, either at the whole school or in the whole year group or a whole classroom. They're about kind of anti-bullying campaigns, anti-violence campaigns, general social and emotional well-being programs. These all fall under mental health promotion. And actually, the evidence base for these is incredibly good and strong. The next stage you've got is mental health prevention intervention. So this is to prevent developing depression or anxiety. So there are lots of kind of types of interventions that have been developed to prevent mental illness developing, but I just want to say to you, the evidence base for these is not very good at all, I think. So we can say with much less confidence, yeah, do this and you can prevent depression developing. And then the last area is the interventions for those that need treatment. And again, the interventions there have a good evidence base, because we know kind of sort of how to treat illness once they get to us in mental health services. So we've got kind of good evidence for promotion, good evidence for treatment, but actually what everyone wants is kind of an improved evidence base for prevention. And I think that's an area that we all need to work together to improve. So just talking through a few of these, promotion ones. So the whole social and emotional learning programs going on around the world. Good evidence base. So examples of these, Mind Matters, which is very big in Australia. I don't know if it's come much to New Zealand yet. There's kind of, and these often work at the student level and the teacher level and the school level. The good behaviour game is getting increasing prominence because it's one of 2 school interventions that's shown to reduce suicide rates over the long term. They've got 25-year follow-up data now on the good behaviour game, which is an intervention that's been developed for primary schools, where basically a classroom's split in 3 and they get points for whichever group behaves better. So it's a real kind of basic positive reinforcement of positive behaviours. There's the whole health promoting schools agenda, which is very, very big. It's kind of thinking about the whole curriculum, the school leadership, the community links. So this kind of where a school sits itself within its environment is really important. And there's a very big a lot of learning that's taken place around this that I think is very important to just accept as actually very, very useful learning, and we need to adopt more and more of these components. And then thinking about preventing mental illness, there are kind of universal interventions, so that's for everyone in the school. So these universal interventions are good because they can fit into the school day quite well. You've got to think practically when you work in schools. There are many CBT based, but again, as I've said, it's very complicated to know what the true evidence base is for many of these. Friends for Life is one example of a preventive intervention. It's CBT based. It's whole classes do 10 one-hour sessions, learning about improving coping skills, identifying feelings, learning to relax. Seems a really good comprehensive thing. It has some evidence to improve anxiety, but it's not as good so far from my reading as we would hope. So, thinking about the indicated treatments, well, those are kind of pretty good evidence based to treat depression, trauma, anxiety disorders. So I thought I'd share a little bit of the learning we've had in Oxford and my experience of working in schools. So these are 3 main areas. One is with refugee children. The second is in developing a toolbox to help teachers manage psychological difficulties. And the third is in how we're trying to change services and bringing mental health services into schools. So the first is with refugee children. So what we did was develop... So we had kind of a lot of refugee kids in Oxford, and none of them were presenting up the hill to mental health services. So what happened was we developed this school-based service where we had a link teacher in the school. We would meet weekly, and we would discuss every refugee child of interest, every refugee child in the school really, as a kind of preventive way of kind of going forward proactively rather than waiting for a problem. And together we'd be able to quickly identify if kind of the different supports could be brought about at school. I suppose our goal was that if the kids never had to see us, that was a great advantage. So doing everything we could to support the environment, to make sure that these kids were able to thrive as best they could. But that if they needed to see services, the school who had a relationship with them would approach them, would tell them about the service, and then would accompany them, if felt appropriate, to the first meeting, either for part of it or all of it, depending on what was needed. And that really facilitated access, and we would do those meetings in the school. So we kind of changed the whole way we work to make it more amenable to these families and children. And we asked 40 of them afterwards, after they'd been seen in refugee services and schools across the country, what were the advantages? Now, 70% of the kids preferred to be seen in school than outside of school. And I think that's probably indicative of all kids. Not everyone's going to want to be seen at school. It's clearly not going to be the answer for everyone, but around 70% I think is probably what we're experiencing is the right number. If you don't like school, you're unlikely to want to be helped too much in school. And if you're worried about privacy, a lot of kids who had privacy concerns also didn't want to be seen at school. But those that preferred being seen at school, the reasons they gave were really around the fact that it felt safe. It was also convenient, they could find the therapist easily, they could get to their lessons on time. And this is a quotation from one of the refugee kids that we saw. "It's good to have it in school. If you come to hospital, it is scary. I don't know if I would go if it was in a hospital. No one likes hospital." Well, obviously, apart from strange people like me that want to be doctors. But, that I think is totally understandable. This is what we would see in the schools, that the teachers would go to them, okay, you've got an appointment in the hospital. The kid would leave school with every intention of turning up at hospital. And then as they're walking, they're going, well, why would I go there? And they'd just go home or they'd go and visit a friend. So actually, providing services within school seemed just a much more natural way to support them in that environment. The other thing I was involved in is developing a toolbox for teachers. So, just accepting the fact that teachers are there, they're dealing with a lot of problems. The children with emotional behavioural difficulties are taking up a lot of their time. And is there a way that we could just give them kind of some skills that they can choose when and where they want to use it? And so we developed this kind of psychological toolbox where in a 1-2 hour session we taught them kind of 8 different skills that we commonly use and just said to them, use this whenever you feel it might help you. So not to be very prescriptive about it, but just to kind of enhance skills. And that's kind of been found in a lot of the interventions around kind of lay practitioners and non-mental health professionals, that giving skills seems to be the most needed and wanted approach. And so this is an example of one of them. It's the treasure box. And it's about kind of going to a child and going, what can you do to help yourself? So it's about kind of building skills, showing young people that there's a lot of things they can do themselves, kind of helping them foster their independence rather than making them feel that they're dependent on services. So teaching teachers how to work through building this treasure box for young people together with them. And this is just data on 100 teachers that kind of 6 months after we taught them this toolbox, we asked them, which of the tools did you use? And what we found was really that the ones around sleep, relaxation, and learning to kind of listen in a different way were the ones that the teachers used the most. So over half had used the sleep and relaxation ones. And when we asked them how many kids they'd used it with, most had used it with 1 or 2 in that time, but, actually about 10%, 20% had used it with over 5 kids. So giving skills to teachers, just letting them find the ways that they want to use it themselves, seems to be an important way to work. And the last thing I want to share with you about Oxford is kind of the fact that, when we went to the schools with the refugee kids, we'd kind of meet with these link teachers every week and we'd talk about the refugee kids. And then we'd finish our meeting and the teachers would go, great, now can I talk to you about these 20 other children at the school that are worrying us? So, from a teacher's perspective, just focusing on certain groups isn't necessarily what they need. They've got children in the classroom that they're worried about. And so on the back of that, we decided, how can we completely transform the way we work so that we can develop services in schools? And so following discussions with commissioners in Oxford who commission mental health services, we first piloted, and now all secondary schools in Oxford have this new model of care where a member from our mental health services, a CAMS worker we call them, Child and Adolescent Mental Health Service worker, goes to a specific school at a specific time each week. So we find with these big schools, they might have 30 kids that are in services, but those 30 kids are seeing, 20 different mental health professionals. So from a school perspective, they're not able to build a meaningful relationship with mental health services. They're building a relationship around individual children. What we wanted to do was change that. What we wanted to do was say, as a school, how can we as mental health services start to interact with you in a different way? How can we build a relationship where you talk to us about young people of concern early, where we together identify whether other services are more appropriate or whether this kid needs to be seen urgently? Because what we find is that schools perceive mental health services as distant, overloaded, never accepting the cases that they refer. So the school then holds on to problem kids as long as they can. They do everything they can. And then when it hits an emergency, they refer to mental health services, and then they have to wait another 4 months. So we wanted to kind of change that, and also to find a way to deliver services for young people at school, because for some kids, for a 20-minute follow-up, a parent has to leave work, drive to the school, take them to the hospital, come back. Like, that's a major disruption to families that are often under incredible stress. So is there a new way that we can work that just facilitates that and gets rid of all of that kind of difficulty? So kind of looking at what these mental health workers did, we kind of asked early on, if you've seen an individual at the school, what have you done? And kind of a lot of them were seeing individual staff to discuss problems and difficulties or worries that they had. And, the other half were kind of doing ongoing therapeutic work with the kids. And when we asked them what the area of need was that they were addressing, for most it was around emotional difficulties and behavioural difficulties. And then we asked the mental health workers going into schools, what do you think has been the impact of your work in the school? And so the top one says useful advice given to staff. And I think for me that's the key thing, isn't it? That we're these two big institutions, we're all working for the benefit of kids. Why don't we work together more? Because it's got to be for the benefit of kids to facilitate that and to enable teachers to hold on to things and manage them if it's appropriate, and to not if it's not appropriate. So talking a little bit about the challenges we've encountered in this work, well, I think ethical has been a major one, getting consent. Should a kid, who needs to know? Do parents need to know? I feel really strongly that kind of, in forcing a kid, before they see us, to have a parent agree for them to be seen is really not helping young kids access services. I call this kind of a design flaw in kids. They're the one group that can't access me. They can't go to the school and go, right, I want to leave and go see the doctor, without their parents knowing. They physically cannot get to services. If there are major, what we call safeguarding protection issues, then yeah, maybe. But actually for the majority of kids, you don't know that early on. And yet we place all these barriers for young kids being able to access care. So these ethical concerns, I think, are really important and really big. Like notes and confidentiality, what we should do, who we should do, where should we write, who should we tell, who in the school needs to know what we're doing. All these are really complicated. When you work in a clinic, it's really easy. You don't tell anyone. You just sit in your clinic. You write a letter to the GP if you want to, and you keep your notes where they are. But the minute you start working in school, I think it can be difficult. The whole issue of screening, should we do it? How should we do it? We're now working in schools, I think needs to be thought about. And then the pastoral care systems within schools. So, you bring an outside agency who are experts, but actually the school has a lot of support systems that are there, and you need to make sure you're not undermining them or threatening them or making them feel worse. Some schools, when we started, their reaction was, oh, great, we don't need to employ our school counsellor anymore. And we were like, no, that's totally wrong. Actually, you having a school counsellor enables us to provide that extra bit of support and containment for the school. But if you don't do that, then actually our time gets spent on issues that actually is not necessarily best use of our time. And space. Schools really have no space for the work that they want to do. So to create space for you to work in their space is obviously going to be a challenge for a lot of schools. So it can't be taken lightly. I thought I'd just quickly talk a little bit about the global context as well. And the other reason why I think I'm really passionate about working in schools. So 80% of the world's children right now live in low and middle income countries. They don't live in high income countries like this one. So 80% of the world's population, of children, of the future generation, are living in completely different environments to this. And what we know about a lot of these countries is that mental health services, particularly for children, is very, very limited. Very, very poor. If you look at sub-Saharan Africa, there are only a handful of child mental health professionals in the vast majority of countries. Yet, there are schools absolutely everywhere. in the most rural environments and the most urban environments. There are, of course, a whole range of different sizes, ethoses, systems, but actually, if we really want to be thinking about the mental health of the future generation, not just of our own country, but globally, I really think we need to get serious about thinking about how we work and understand how we can best support mental health within schools. Because actually, it's going to be, I think, the only way we can reach the large proportion of the world's population. And I'll give you an example of an interesting project going on in rural India. It's called the SHAPE program, where they trained lay people, because obviously we shouldn't assume that teachers are going to absorb all of this, but why can't lay people come more into schools? And they trained lay people, no mental health background, to do a number of tasks. One was to screen for visual and hearing difficulties, but also to provide individual counselling. And the counselling that they provided was closely supervised the first day they worked, but after that they were able to do a lot more on their own back. And also to bring in whole school violence and bullying prevention strategies. So there are, I think, interesting examples of how to work with the system of schools in a different way. So now let's get to what can be done. So what are policy and practice implications? So the first thing I was involved with was doing a big survey of the 8 largest school mental health programs around the world. So what we know is that there's a lot going on. So these 8 programs alone have reached over 28 million children. So what learning there is, I think we need to make the most of. So the largest of all is called PBIS, which is Positive Behavioural Interventions and Supports. Around 10 million children have at least 10 million have been through schools with this program. And it's improved reading scores and fewer suspensions in the schools where it's been done. So this is, you don't need to worry about this slide too much, but just to give you a list the different programs and the numbers involved. And so kind of what we can learn from these 8 programs is that of the largest studies, 6 of them are delivered by teachers, 2 are embedded in the school curriculum, a few are tailor-made and have been adapted, and many include what we call Tier 1, so components for absolutely everyone in the school, and then targeted approaches for others. So what factors impact on the quality of mental health interventions in school mental health? So I think we need to think about this in terms of kind of individuals, universal, the whole school, and then the whole community. And I can send you these slides if you want to know the details of this. But I just think we've got to think that if we want to do things in schools, we shouldn't just be thinking in a limited way on a program delivered by somebody in one way. That actually there's a whole system that we need to be working for. And so I've tried to demonstrate it like this. Okay, so you've got your child, but they're part of they're in a school system where there are teachers, where there's the curriculum, where there's kind of need to learn, but there's also kind of this whole family. There are peers, there's the whole community, and then there's that last bit, which is, social media or public policy or whatever you want. But basically, we've got to be thinking about this all as interrelated components. And if we really want to address the needs of a child, then we need to be thinking about all of those components when we're working with school mental health as well. So what should we do? I think we need to promote early identification. We need to reduce the duration of untreated mental illness, because there's really good evidence that there's an initial study that came out last year from the UK that showed that if you treated depression in 14-year-olds, those that accessed care had much better outcomes when they were 17 than those that didn't access care. They were 7 times less likely to have depression at the age of 17 if they'd accessed care at 14 versus not, which just shows the importance of being able to identify and access and treat early. We need to think about the teachers. I think we need to think about vulnerable populations and this concept of school belonging, how important it is to feel that you're part of a system, that you belong. And then I'm going to talk a bit about implementation as well. So screening. I really think we need to think about moving from reactive services to proactive services. It's not good enough just to wait for problems to emerge. We need to know who needs care now, obviously, and who's not thriving, but we need to really be thinking about how best to screen. And I don't think we know. Screening can't be that everybody fills a questionnaire. It might be. It might be that teachers nominate the 3 kids they're most worried about, and you do a more in-depth assessment of those. I think the method is open for you to decide for this context. This is an example of a survey that's used in America called the Social and Emotional Health Survey. And this is the results of a whole class. So it's really interesting that it looks at kind of 4 different areas. It looks at children's belief in themselves, in their belief in others, their emotional competence, and their kind of engaged living, whether they show gratitude, zest, optimism. So it would be really interesting. Imagine if you're a teacher of a class and you get to see kind of the composure of your class now, that actually a lot of people in the class feel that they don't have good peer support, for example. But you could also get that kind of profile for every child in your class individually. And would this change the way in which you approach your kids? You feel about what you need. So I think we've got to really think about our teachers. We've really got to think about how best we support teachers, how best teachers are prepared in their teacher preparation programs. I know in New Zealand you're doing a lot more than most other countries to focus on teacher preparation. In England, there's not even anything about mental health in the majority of curriculum for teachers. And I've never had a trainee teacher come and spend a day with me in my work, and I never, did much in schools in my training. So we're not even contributing to each other's kind of training and development. But we know that we've got to prevent the burnout cascade. A good teacher is worth their weight in gold. We have to do absolutely everything in our power to support them in their work. And I think that a teacher's preparedness to kind of look at mental health needs is predicted by their training, the resources they have, and availability of coaching. So I think that we've got to really seriously think about how we support teachers. And then thinking of really about what to do and how to work and what in the prevention agenda, I suppose my conclusion is also that we really need to think about targeting those that have known risk factors. So there are really well-known risk factors. Those that are exposed to family discord, be that separation, be that substance misuse, be that incarcerated family members. Those that are victims of abuse, in particular those children that have been bullied. Those that have physical health problems, we know have higher rates of difficulties, or parents with mental health or physical health problems. Those that have early puberty. Those that self-harm. Those that are migrant or displaced. That we really need to be thinking in a targeted way about how to particularly support those. And I suppose don't forget kind of the difficulties of family discord and chronic family adversity. So, what role can schools play in helping families, that are suffering? Very few schools actually think this is their responsibility, and it's obviously highly complicated. But from a child's perspective, which other institution is there that's going to potentially help them navigate the complexities of the home in which they're living and the difficulties they might be facing? So is there a new way to conceptualize responsibility, roles, helping families that are struggling? Doesn't have to be the teachers that do it. We could be finding ways to develop this in a more structured way within schools. Thinking about bullying, schools with programs to address bullying are more likely to identify and support victimization. So we really know that there are quite a few good comprehensive examples now that have completely changed the way we believe we can impact on bullying. And many of these are kind of multi-level approaches of dealing with staff room, dealing with a whole range of practices around kind of how to report bullying, how to support kids that are bullied, and that I think that this is a basic thing, given how toxic bullying is for future mental health, that actually needs to be supported and fully kind of adopted in schools. And like I said, don't forget the importance of school belonging. The fact that school can help build interpersonal relationships, can really help with these important tasks of adolescence in exposing them to kind of places where they need to learn to regulate their emotions and develop. And I'll just end with a few slides on implementation. So I think what's happening is that although these interventions exist, a lot is falling apart when it comes to the implementation of them. So interactive interventions seem to have the best outcome. So things where people do things actively, not just sitting and didactic learning like this right now. So I'll stop so you can ask some questions. But integrating things into routine schedules and ring fencing resources and time. They're so complicated being a school. You have so many pressures that, I totally understand our mental health is a lower priority when the school's judged on its attainment and attendance statistics and providing more learning support and all the other things that have to be done. But I'll show you a slide of this young man who I don't expect any of you to know, but he's a guy called Ted Baker. Now, he managed an incredible feat in Britain. He managed to escape from Pentonville prison, which is a really, really difficult prison. Okay, so he managed to get a drone, we think, to deliver a diamond bit into the prison, managed to cut his way out of prison, managed to hide the fact that he'd left prison by making his bed look like he was still sleeping in it, and he got out of prison a couple of years ago in London, only to be found by the police the next day hiding under a bed in his sister's house. So this is, I think, the importance of implementation, that you've got to get beyond not just kind of finding the right way out of the prison, but you've got to stay out of prison and kind of have a plan to sustain and kind of, build how is this going to not just be, okay, we're going to do this program, how is it going to be sustainable? And kind of the most low intensity, the most scalable, and likely to be the most important. And so what we know is that, it can take 17 years for original research to change practice, and we need to change this cycle of implementation. We need to start adopting and learning much quicker, and there's a lot of learning in schools that we can draw on about how to get school leadership buy-in, the components that are needed to change. So in conclusion, I think we've got issues that are specific to adolescent health. We need to think about, I think there are ethical reasons why we should be working in schools, because I think it can democratize access. We can access all children. It's not just the sole subsection that can access. And there are also scientific justifications, because there are evidence-based interventions. There are ways that we can work that can help. And so, we need to develop interventions that are part of a system of care. We need to look after teachers. There's good evidence of mental health promotion. I think we should focus on vulnerable groups and refer early to services to those that need it. So I'll stop there. Thank you very much for all your time.
You're talking about adolescent health, but I assume you're talking about interventions across primary, intermediate and high schools, not just in high schools. Is that correct?
Yeah.
Yep.
So, for example, the Good Behaviour Game is a primary school intervention. And I think we just have to accept that these are very different age groups. And so even early adolescence seems to be very different to late adolescence. So I do think we need to not assume that one thing is going to address all. So I think kind of what we've learned about anti-bullying, I think, has principles that are important across all of those. But the teenage years is when major mental illness develops. And it's, I think, closely related to puberty. So what's needed in the teenage and high school, I think, is different to what's needed in the primary school.
I'm from Counties Manukau Health, so one of the DHBs, and I guess the information you were presenting about prevention was a bit disappointing, because I guess we were hoping that there might be something in the primary school years that you could implement when kids were still engaged with school, and make a difference to that trajectory, because what we find is a lot of our kids are disengaging 13, 14, and they're not actually in the school, the ones that are at highest risk. But it sounds like that may not have an evidence base behind it just yet.
It doesn't have the evidence base from my reading of the evidence. But I do think, early on, supporting families within the school context, supporting other factors that might be leading them to be disengaged from education is often educational difficulties. If they're having difficulty learning, then they're like, they get this negative cycle of achievement where they just feel worse and worse about themselves. So those are likely to help, but the good evidence base about preventing future mental illness isn't clear. But there's good evidence about how to support them to stay in school, which would be around addressing some of those types of factors.
And working in this space a lot, actually. I'm also president of the Waitakere Area Principals Association, and we have a particular focus on learning support. And we go backwards and forwards to the Minister all the time about interventions and how we can best support schools to actually be able to deal with some of this stuff. I know that the mental health services around my school and out west pretty shocking, and that trying to get access, is your word, it's just abysmal. Like we get access finally after having gone through all the various agencies we need to do, and then they say, oh, no problem here. And so it's like, it's broke. The system in New Zealand is broke, and the Minister accepts that. And I'm quite passionate about this in my own school, and we're trying to set up systems where we can better access the services that are available. I don't know if you've heard of, through the AE space, which is the alternative education space, there's MMSs, can't remember the term, but these guys have been employed to actually get the services around children at 13 to 16 so that they can get them better able to meet the system at the level that they can do it. And we're trying to bring that down to 5-year-olds, and we're doing a little study to see if we can do that. But again, it's about getting the resources, because it all costs money, and we're trying to release a teacher and a teacher aide to try and work in a smaller setting, so 5 to 10 kids that are, we've got 5-year-olds coming through that are P babies. We've got extreme behaviour in classrooms that never saw 5 years ago. Yeah. It's like, and it's coming, there's masses of them across Auckland, I'm sure across New Zealand, and there's just nobody knows what to do about it. So it's interesting. That's why I'm here. Yes.
So I think that is a global phenomenon, I think, since, the evidence is showing since 2007, 2008, rates of violence have increased. All the markers were going down, and then there's been this downturn, and things have changed. And in the UK, we see the same, so increasing numbers of cases, but each case is much more complex on arrival than they used to be as well. So I think, what we've got to think is, what structures are there to be working with this? And actually, I'm a full proponent of doing everything we can to support schools, because you seem to be in a uniquely strong position. But it shouldn't be that schools do it all. There should be a way to facilitate other agencies and lay professionals, lay people trained up. We've got to think of sustainable, scalable, low-intensity ways to start to address these problems.
Yeah, really, Toko will confirm or support what you're saying, because I believe strongly that schools are where it should happen, because we have the relationship with these kids. We see them 5 hours a day. They feel safe where we are, generally. They have the relationship with other kids their own age and with older kids. That's the area where it should be supported, but continually struggling. And it's really nice to hear from a psychiatrist that they think that should be happening too, because
absolutely, yeah, often
you guys are way outside our being completely.
I'm interested in schools, and I only went twice in my whole training into a school. It's absurd. Really, if we're working in the same area with the same kids for the same purpose, but then, it's reflected in government, isn't it? There's a Ministry of Education and there's a Ministry of Health. That just doesn't make sense from a child's perspective. Actually, we need to be thinking in a much more kind of integrative, cohesive manner.
And that's happening in New Zealand. There's the Commissioner for Children, Andrew Beecroft. I was listening to him yesterday talking about, there's at a high level, there's talks going on to try and join things up, but But actually those talks seem to go on and on and on and on. So at school level, we've got to deal with it now. It's good that those talks are going on, but actually we need to deal with it now, so something needs to happen now.
Yeah, so there's two things. You need to reap and sow as well at the same time, I agree. And I think we from mental health need to learn to speak the same language. So, we talk about mental health symptoms, this and that. Schools are often thinking about attainment and achievement, but we can also talk in that language. So we also need to learn to be communicating in a way that's more meaningful, I think.
I'm actually working on the government's inquiry into mental health and addiction at the moment. And one of the things that's coming through was echoed in what you were talking about, which is, I guess, the question of what are hospitals for? If it's clear that there's some resistance to having your treatment in a hospital, maybe there's a stigma attached to it. Can you comment on? Just an anecdote. One of the things that we're hearing as we go around the country is a lot of clinicians expressing some lack of confidence in their own model as this sort of up on a hill group of experts to whom you have to climb the hill to go there, and they are asking us. Yeah, a lot of them are. They're pretty much all on hills in New Zealand. Is there a different model which is I guess breaking the mold of that group of experts who do this magic thing?
Yeah, so I think there's, globally, we've just finished a big review on what community mental health interventions means from a global perspective that I'm happy to send to you. So I think the issue is we need to get to scale now. We need to be addressing the needs of a large number of people who aren't being accessed by services. So we have to think about new models of working and new ways of working. So, whatever the hospital is for, it's not addressing the needs of those kids that I'm interested in, which is about accessing care. So I think it's about how do we facilitate better mental health care in community settings, because that's where the children are. So when we started our pilot in Oxford of the mental health workers going to schools, with one of our first schools, we went to the head teacher, and the head teacher went, "No one in the school is going to want to see you at school." We were like, well, so every single kid we phoned who had from that school who was referred into services, we'd phone them and say, "Would you like to be seen in mental health services, or would you like to be seen at your school?" And the head teacher was right. 100% of kids went, "I don't want to be seen at school." So after a year of working at the school, doing assemblies, being seen a little bit more at school, doing that, within that time, 100% of kids started to want to be seen at school. So it's also just about, are we addressing issues around stigma, fear? So it's also just, learning, through things like that. And I remember once she came back, our mental health worker, from another school actually, she'd done a sixth form assembly. And at the assembly, one of the most popular teachers stood up and went, "Look, kids, you all know I was sick last year. I had mental health problems, and it helped me so much to go and access care." And I thought that one teacher standing up in front of all the sixth form, the last 2 years of school, and saying that is going to change that whole kind of generation's perspective on how to access care. So I think what we've got to learn is, how do we make ourselves more accessible? Just like banks, had to become online and 24 hours when they used to have this model, we need to change the model that we work, because actually it's just not acceptable not to access anymore. So I think hospitals are going to play a role for the severely unwell, I think. But that's a really tiny proportion of need. Yeah.
Hi, Anihira and Mike from Changeworks Family Action. We're in West Auckland. We're a counselling organisation. We work in schools and do school groups and things for at-risk youth that are identified by the school counsellors and that. I really just wanted to say thank you, because I really appreciated the concept and what you've already done, but of going in and looking at identification of kids at risk, so from the preventative side of things. I think a big thing for us is relationship with the schools, with the kids. I was interested. I'm glad you spoke a little bit about how you started that relationship with the schools and how you get it in there about, let's do this thing where we come in every week and something like that. And I can already see how we could implement something like that, go a bit broader with the work we do. So I just want to say thank you.
Great, good luck. And I'm here to help if I can.
Okay, thank you.
I just want to say thank you very much for your presentation, but I'm a kindergarten teacher, and I'm really interested in your prevention, that no mention was made of the early years, and I'm wondering how you relate what's happening in adolescence with the first few years of children's life.
Yeah, so, I think, what the kindergarten teachers will say to us is we know very clearly which of our kids are going to be developing, difficulties later. So, that's a very clear message. I think we just, it's not my area of expertise. I think there's a lot of focus that has been done on those early years and reasonably good evidence to show how important it is. Unfortunately, what we're finding in the UK is all of that is being ignored and all these services are being dramatically cut. So I think they're very interrelated and they're very kind of important. But I suppose from my perspective, in schools and adolescence, that was just my focus, is actually what are we doing about this kind of really complicated stage of kind of massive change and great kind of pubertal change, physiological, emotional, social changes, and how do we address that? But, the early years are incredibly important. Yeah.
All right. Well, I could actually keep listening to you for ages, and I'm sure many of you in the room could as well. And I was reflecting to myself, being the mother of now young adults, I wish I'd learnt some of this stuff about 5 years ago, because it might have helped me navigate the last few years. But thank you, Mina. It's been incredibly informative. I've learnt so much already today. And, just the whole importance of things like access, and you were raising the questions before about that. The significance and the importance of schools is just fundamental, and the multifaceted responses that you've taken us through have been quite equally interesting, around like the toolbox and the use of that for different layers within the ecosystem to actually find mechanisms and ways to support them. I think my key message there is about looking after teachers, and that to me was a core component of how we can move us forward, is actually working with our schools, with our teachers. So thank you so much. Mina is incredibly generous. So we're cracking the whip on a huge program for her over the next couple of days, and she is, her generosity of spirit is fantastic. So I do want us all to acknowledge Mina again, and thank you. So lastly, thanks to you all for coming along today. I'm sure you can probably grab a few minutes if you wanted to try. I'd like to acknowledge KPMG for hosting this, and for our team, Amber and John, who've particularly worked hard on this, but for everyone else in the team, thank you guys. And then the last thing for Mina, and I don't know whether I should say it publicly, but I do know the score from the soccer. And it did go all the way to extra time. However, you know the answer. So thank you, everybody. Enjoy your day. Thank you.